Thank you very much, Lady Chairman, and good evening, ladies and gentlemen. I'd like to start by thanking the Scientific Committee very much indeed for inviting me to contribute to this prestigious conference. I'm going to talk about congenital adrenal hyperplasia in the next 20 minutes or so. And during my talk, I would like to throw some highlights on the different forms of congenital adrenal hyperplasia. I would like to also highlight the dilemma of sex assignment in this disease. And I would like also to talk about the fascinating phenomenon of genotype-phenotype correlation in this disease. So just as a refreshers for yourselves, ladies and gentlemen, CAH, as you know, is the commonest form of steroidogenic defects in the adrenal gland, with over 90% of CAH cases resulting from CYP21 gene mutation expressed as 21-hydroxylase enzyme deficiency. Majority of this enzyme deficiency result in salt wasting type, and there are multiple hotspots known to occur in certain population when it comes to the genetic mutation of this disease. This is the complex pathway of the adrenal steroid synthesis, which I'm sure you are all familiar with, but it's just a refresher for your minds, highlighting the three main columns for glucocorticoid, mineralocorticoid, and sex steroid synthesis. And I flag the key enzyme here by the red arrow, the 21-hydroxylase, which is the commonest enzyme deficiency in this disease. Let me start by the commonest case scenario of CAH. So this is a 10 days old baby who presents with poor feeding, lethargy, looking dehydrated, hyponatremic, and hyperkalemic. And on examination, this baby has ambiguous genitalia, so we don't really know whether to call this clitoromegaly or micropenis. And our initial impression is not backed up by palpable gonads, which makes decision on clinical impression quite difficult. Biochemistry in this disease presentation will show a raised 17-hydroxyprogesterone as well as raised testosterone and renin. So this is a classical textbook scenario of salt losing CAH due to 21-hydroxylase deficiency presenting clinically in salt wasting or adrenal crisis. But let me show you the same diagnosis, the same everything, but slightly different scenario where it makes diagnosis a little bit harder in this condition. So this is a baby, first baby to non-consanguineous parents, and this baby is born with impalpable gonads. So this is a picture of the genitalia of this baby, and as you can see, the size of genitalia is relatively okay considering the borderline prematurity of this baby. You can see that the scrotum is normal, rugated, the phallus is of reasonable length, the urethral meatus as well as the anal orifice are both normal. Nothing wrong in the systemic investigation examination, but the gonads in this baby are not palpable. When we look at the biochemistry of this particular child, you will notice that his 17-hydroxyprogesterone is extremely high. His testosterone and the renin are also high. Looking at urinary steroid profile, as I flagged up in the slide, the 17-hydroxyprogesterone metabolites are very high, and conversely, the cortisol metabolites are low. And then the first thing that we think about, what sort of karyotype does this baby have? Is it XX or XY? And considering that the karyotype needs some time to get the results of, we did a FISH test for this baby, fluorescent in situ hybridization test for the X chromosome, utilizing X chromosome probes. And as you can see the results from the fish in the picture, you can see 2 dots in each cell indicating XX. And the karyotype for this baby was 46XX. Despite the male-looking genitalia. Genetics of this baby confirms that the patient has CYP21 complete deletion of the gene, and both parents were carriers of CYP21 deletion. So overall, the complete picture is now clear on this baby, in that the baby has severely virilization at a grade of Prader stage 5 of CAH due to 21 hydroxylase deficiency due to the gene deletion. So this is one spectrum of the disease. Deletion is a severe type of mutation leading to a severe presentation of the clinical picture. And now let me talk a little bit about how to sex assign this baby. I showed you the genitalia of the baby, and I did tell you that his karyotype is 46XX. The gonads inside are ovaries, the testosterone is high, the active androgens are high, but the internal genitalia is that of female. And there might be androgenization of the brain because the brain is sensitive to androgens. So there might be some tendency to the male sex when it comes to gender identity. I asked this question to over 200 endocrinologists in one of our endocrine meetings, and it appears that there are consensus. 97% of the audience voted for a female sex of this baby. And that comes from the long-term studies in the literature, where over 90% of patients with severe virilization of 46XX, they identify themselves as female when they grow up. And when I asked the audience in that particular conference as to why would you suggest the female gender of assignment, people said, because we know the diagnosis and we know this is the best thing for CAH, female who identify themselves as female in the future, as well as because the karyotype suggests this. So we put together an interesting paper that was published recently in the JPM, talking about views of sex assignment in different categories of disorders of sexual differentiation. I have always been fascinated by this area of sex assignment, and over 20 years ago, during my training in the UK, I worked in a more difficult cohort of patients of partial androgen insensitivity syndrome, where things are not really black and white, and it was very impressive what our findings were from this study, where culture, religion, parental choice all influence the sex assignment in babies. So it's not purely the physician's opinion and the investigations. So let me go back to the presentation of CAH, and I discussed with you the very first presentation of the classic form, the severe phenotype due to severe underlying genetic. But let's go and see another form of CAH, the simple virilizing form. So here is a child who was referred to my clinic at the age of 4.5 with precocious puberty features and a testicular mass. He was referred thinking that he has Leydig cell tumor in his test. That's how his genitalia looked. Very similar to adult genitalia at the age of 4.5. He had advanced bone age. And again, his 17-hydroxyprogesterone, his testosterone were very high for his age. His bone age was advanced. And he didn't have any positive tumor marker expected to be seen in testicular tumor. This is an MRI showing the testicular mass, and this is how his genitalia looked when he went for a biopsy of that palpable testicular mass. And this is a closer look of the macroscopy of the mass in the upper pool of his left testicle. Now, the interesting part is what this mass is. And on biopsy, it stained very positively to a stain called synoptophysin. This stain is known to take very strongly if cells contained ACTH. So the idea was very much into testicular rest tumor rather than carcinoma of the testis or Leydig cell testis. So we published this case as an unusual presentation of simple virilization due to testicular adrenal rest tumor. It's very unusual to see testicular adrenal rest tumor in simple virilizing form of CAH, and it's not usual for it to present unilaterally and that big to be detected clinically as a first presentation of the disease. And the final part of the clinical spectrum of this disease, we've done the classical form. We talked about the simple virilizer. The end of the spectrum is the non-classical disease, where this girl is a classical example of, so she's a 16-year-old girl who presented with irregular period, hirsutism and obesity, and she had high metabolites of 17-hydroxyprogesterone. She had polycystic ovary on her ultrasound exam. Now, this is a non-classical CAH, and while it can be considered as a mild form of CAH, it's quite an important disease because there's high likelihood of comorbidity on cardiovascular disease. This is a study that we have undertaken in Cambridge, again during my training, looking at insulin sensitivity and body composition in children with CAH. And we found clearly that patients or children with non-classical CAH are likely to have insulin resistance, leading in future to the metabolic syndrome. So same disease, ladies and gentlemen, CAH, but different presentations. Classical, salt-losing, simple virilizing, and non-classical. So this is the clinical side. And let me move now to the underlying genetic condition. So CYP21 is the gene in concern here in relation to CAH. It's quite a complex gene. It resides on the short arm of chromosome 6 within the class 3 of histocompatibility antigen. And there's a very complex way of when it comes to gene expression and transcription, because there's a lot of interaction between the actual gene and the pseudogene, and multiple conversions can result from that, leading to the disease phenotype. And the gene is quite big, spanning 10 exons over the area that I'm flagging up. And what I find really fascinating in this condition is the elegant correlation between the genotype and phenotype. So the more severe the genotype, for example, the deletions and specific mutations that you see to the right on this arrow, the lower the enzyme activity and the worse or the more severe is the clinical phenotype. This is an important study published by Marianne Yu and her colleagues. Marianne Yu is very well known of her special interest in CAH, and this paper in particular has enriched the CAH literature. Marianne Yu looked at 1,500 families of CAH, and she highlighted the different mutations in these people, particularly in relation to their ethnic origin. So she showed the same thing, this correlation. Severe mutation leads to severe disease. And she showed over the exons of the CYP21 gene where these mutations are. But the fascinating part I find about this study is where and what type of mutation we see in different populations. So there were many Caucasian, whites, Europeans, Swedish, and Dutch, and there are others like Argentinians, Mexican, and there were some from our region, Middle Easterns. And there was this huge difference between the type of genetic mutation in different population of people. And if we look at the Middle Easterns in particular, you can see here in our population, intron 2 mutation is far more common than others, particularly the deletion. this is a cartoon showing some work that I did in Cambridge, showing that the deletion in CYP21 in these Caucasian families is more common than the intron 2 mutation, something that's opposite to what Marianne Yu and her colleagues show. And let me just quickly show you some other studies from the literature when it comes to the same concept. So this is a study from China looking at the same concept. Which mutation is more common in this population? First of all, in China, they showed the same correlation. Over almost 90% of genotype phenotype correlate. The deletion was less common, so it's similar to our population in the Middle East. And in Portugal, even though it's a European country, the same was seen. Deletion is less common than the splice mutation, similar to China, similar to us, the Middle East. And in India, the same thing. So it's very interesting that different ethnic groups have different predilection to a different genotype. And I will finish in the last remaining 5 minutes of the talk to give some highlight on the non-CYP21 CAH, which is the one that's less common but equally interesting. Let me share this case with you. So this is a 32-year-old female who presented at 17 years of age with absent secondary sexual characters and primary amenorrhea. She was noted to be hypertensive, hypokalemic with pigmentations in her palms. She had a karyotype of 46XX and clear picture of hypergonadotrophic hypogonadism. Now, her adrenal profile was very interesting in the sense that she only had high aldosterone. She didn't have anything else. Almost everything else in terms of adrenal hormones were undetectable. Not only that, but she failed her synaxin test. Her cortisol remained very low while her ACTH was high. So this is a typical picture of a patient who has adrenal deficiency. That's easy to diagnose. But what was not easy to diagnose is to pinpoint where the defect is. So if you go back and look at the adrenal steroid synthesis pathway, I am flagging where the defect is with the red arrow. So that's where her mutation is. And she's not able to convert any of the adrenal metabolites beyond pregnenolone. So what happens with her is she has no glucocorticoid metabolites, no sex steroid metabolite, which will explain her adrenal insufficiency and absence of secondary sexual character. But she had plenty of mineralocorticoids, which explains the hypertension and the hypokalemia. So her case was published by colleagues from Bart's Hospital in London, showing that where her defect is, and this is Western blot showing the defect of conversion of pregnenolone compared to the wild type, the normal gene in the control studies, and this is mapping of her novel gene mutation that was done as part of her functional studies in London. I am a pediatrician, so you might have been wondering, why did I come across the 32-year-old female? Well, I did because I came across her sisters who were much younger. And I was called one day by our emergency room for one of her sisters who presented with severe headache and hypertension. The same story. Her three affected sisters all had the same thing: hypertension, absent secondary sexual characters, hypokalemia, and when we looked at their mutation, they had the same mutation. And we published this case coming up with some important insights. What I noted in these 3 or 4 siblings is that their hypertension persisted despite replacement of the corticosteroid therapy. They remained hypertensive and they needed antihypertensive medications on top of the hydrocortisone replacement. What we also noted in these three siblings is that their breast development was poor, despite the fact that I did start their induction of puberty at the recommended age and following international guidelines. So the message is we need to be very careful when we assess people with high blood pressure and hypokalemia, and we need to consider these conditions. So just to finish up with, these non-CYP21 conditions are really a group of fascinating diseases. This is a study from Turkey where they looked at, again, genotype, phenotype correlation and other types of genetic conditions besides CYP21. And they concluded that in a consanguineous families community like that in Turkey, there are multiple novel mutations and the genetic features can be quite heterogeneous. And then we heard from our colleague Ali Zahrani and his group from Saudi Arabia, a very impressive paper that was published in Molecular and Cellular Endocrinology, showing a similar approach. But Ali Zahrani and his colleagues, they decided to look at non-CYP21 conditions and in these highly consanguineous areas in Saudi Arabia. And they showed us how heterogeneous the phenotype can be in non-CYP21 CAH. So I came to the end, Lady Chairman and ladies and gentlemen, and I would like to conclude that CAH is a fascinating disease, and it is associated with a very variable clinical picture. Sex assignment in this disease, particularly for us pediatricians, where we see patients presenting with ambiguous genitalia, can be a real dilemma. It's quite a big and complex field, this area of sex assignment. And the underlying genetic mutation is variable in specific population, but knowing the correlation is very important because that helps us not only to diagnose further family members, but it helps us to direct and counsel patients and predict complication and severity of the disease. And with that, I stop, ladies and gentlemen, and look forward to your comments and questions. Thank you very much indeed.
Thank you, Asma, for the excellent presentation and amazing work that you were doing, and also the CAH is very fascinating, and we do have a lot of CAH cases in this part of the world. I'd like to introduce our next speaker, Dr. Hissa Al-Kandari. She's a consultant pediatric endocrinologist, looking forward for developing a field of pediatric endocrinology and diabetes in Kuwait. She is also a speaker in local and regional international conferences. She has great interest in research, especially in the field of registry and genetic diagnosis of rare diseases in diabetes endocrinology. She is currently leading a project of National Diabetes Registry and Monogenic Diabetes in Kuwait. Dr. Hissa is devoting herself for volunteering work also, and she has been leading Kuwait Diabetes Society for the past, and she is the founder of the National Diabetes Camp of Kids, Future Diabetes Camp for Kids qualifications. She's a very known figure in pediatric endocrinology. I'd like to welcome her, where she will give us a talk about polycystic ovary syndrome in adolescent. Thank you. Welcome, Hissa.
So, good evening, ladies and gentlemen. Thank you, Dr. Afa, for the introduction. I'd like to thank the organizing committee for the opportunity to participate in this conference. I suppose this is a Meet the Expert session, but I don't see myself as an expert in the field of polycystic ovary in adolescents. I'd like to, in the coming 20 minutes, to highlight the challenges and the controversies of diagnosis and managing adolescents with polycystic ovary syndrome. And I'll start with the clinical case scenario that I met, or she came to my clinic 10 days before this presentation. We have Suha, who is a 12 and a half years old girl, presented with growth of dark hair on the chin, lips, and with that, pigmentation on the neck, the axilla, and also a rapid gain of weight for the past 2 years. Mother mentioned that she started to have the signs of puberty only 6 months before presenting to the clinic, and she was living a sedentary life during the COVID-19 pandemic. She had no past medical history of note, and she has strong family history of type 2 diabetes, dyslipidemia, hypertension, and polycystic ovary. Her height was 156, her weight was 96, with a BMI of 41. She had a high blood pressure of 140, repeated twice. She had acne, but mild acne, and she had acanthosis nigricans. She has thin line of mustache on the upper lip. Trying to evaluate the hair that she came complaining of. She had a cosmetic laser therapy for the hair on the chin and the face. Examination of the revealed white striae, and she had tanner stage pubic hair 4 and breast 3. So, does Suha have PCOS, especially with a family history of PCOS? Or is it only puberty? Or is it something else? Is she at risk of developing polycystic ovary syndrome? These are the questions that came to my mind when I was counseling the mother and the child for her presentation with excessive hair growth. We know that polycystic ovary syndrome is a disorder primarily characterized by signs and symptoms of androgen excess and ovulatory dysfunction, disrupts of hypothalamic pituitary axis function. And the typical clinical features include hirsutism, irregular menses, chronic anovulation, and infertility. It affects 8 to 13% of women of reproductive age and 6 to 18% of adolescent girls, depending on the diagnostic criteria used. The diagnosis of polycystic ovary syndrome in adolescent is very challenging, and there is a lot of controversies around the diagnosis, as I mentioned, management, and care for these children. There's a lot of overlap of normal pubertal physiological changes, as with our patient Suha, irregular menses, acne, polycystic ovaries, with the adult PCOS criteria. And there is a risk of underdiagnosis, delayed diagnosis, and overdiagnosis of these children. There is a huge knowledge gap when it comes to the diagnostic criteria, the laboratory normal values, the normative features for these children. And there is also lack of evidence. And the consensus statements are mainly directed toward sending recommendation to the women with polycystic ovary syndrome. The latest guidelines, the international evidence-based guideline for the assessment and management of PCOS, have had a strong consensus recommendation on the criteria of diagnosis of polycystic ovary syndrome in adolescent girls. And it has clearly defined the polycystic ovary syndrome diagnosis as having irregular menstrual cycles according to time post-menarche. So we have to relate to the time to post-menarche, and clinical hyperandrogenism, including severe acne and hirsutism, and or biochemical hyperandrogenism after exclusion of other conditions. Excluding other conditions is always there in most of the clinical guidelines. We know that it takes 3 to 4 years post-menarche for an adult menstrual cyclicity to mature. And by third year after menarche, 10 or more menses occur annually in 90% of adolescent girls. Around 41% of girls achieve ovulatory cycles by the 4th gynecological year. So menstrual irregularity is part of the physiological maturation of the girls as they go through puberty. The guidelines have clearly defined the irregular menstrual cycles in relation to the post-menarche timing. if the irregularity the timing of the presentation is less than 1 year post-menarche, this is considered as normal pubertal transition. Between 1 year to 3 years post-menarche, if we have cycles less than 21 days or more than 45 days, is irregular. More than 3 years post-menarche, again, less than 21 days, more than 35 days, or 8 cycles per year. From more than 1 year of menarche, if any one cycle more than 90 days, this is irregular. And if we have primary amenorrhea by the age of 13, or more than 3 years post-telarche. The other feature, which is clinical hyperandrogenism, in adolescents, is the severe acne and hirsutism. We rarely get the baldness, the male type baldness. So hirsutism defined as excessive terminal hair growth in male pattern distribution in women. And the preferred assessment or scoring for this hirsutism using standardized visual scales, modified Freeman-Galway score, with a level of more than 4 to 6 indicates hirsutism depending on ethnicity. And this scoring is done on 9 areas: the upper lip, chin, the neck, upper chest, upper abdomen, lower abdomen, upper back, lower back, upper arms, and thighs, from 0 to 4, depending on the type of hair that we see. It's terminal hair and should be assessed and scored clearly in the file. For the severe acne, it was specified as severe acne because mild comedonal acne is common in adolescent girls, but moderate or severe comedonal acne in early puberty or moderate to severe inflammatory acne during perimenarcheal years is uncommon. The other criteria to identify kids or children with adolescents with polycystic ovary is to have biochemical evidence of hyperandrogenism by using calculated free testosterone, free androgen index, or bioavailable testosterone, and preferably to use high quality assays, liquid chromatography or mass spectrometry. We can also check androstenedione on dehydroepiandrosterone cell phase could be considered if total or free testosterone level are not elevated. And as was clearly mentioned by Dr. Asma in the previous lecture, that androstenedione and dehydroepiandrosterone are useful to exclude other causes of hyperandrogenism, especially adrenal causes of hyperandrogenism. Once we have this level done, we need to carefully interpret the level of androgen by considering the reference ranges for the population, for the laboratory, and for the age group. And if the adolescent is on OCPs, we need to withdraw the OCPs and do the testing and evaluation only 3 months after the withdrawal. And when we do not have clinical hyperandrogenism, we need to have the test done using appropriate high-quality assays. What about the pelvic ultrasound? Pelvic ultrasound is there in the adult guidelines, but in adolescents, pelvic ultrasound should not be used for the diagnosed PCOS in those with gynecological age less than 80 years, due to the high incidence of multifollicular ovaries in this life stage. As you know, increased gonadotropin stimulation leads to increased ovarian volume and follicle growth, giving rise to appearance of multifollicular ovaries in adolescent girls. So we need to delay the pelvic ultrasound till 8 years post-menarche. Again, anti-Mullerian hormone should not be used as an alternative for detection of polycystic ovary morphology or as a single test for the diagnosis of PCOS. AMH concentration reflect the ovarian reserve and are correlated with the number of growing follicles and are often elevated in women with PCOS. However, there is emerging evidence with the improved standardization of the assays and establishing cutoff levels based on population and different stage of ethnicity. AMS in the future will be a more accurate testing and detection of polycystic ovary and morphology. As in the criteria for diagnosis, we need to exclude other causes for hyperandrogenism. And we need to do that through thorough history taking, physical examination, and sometimes we need to go for lab investigations and imaging. So we need to rule out etiologies of menstrual irregularities and hyperandrogenism. And in adolescent girl, we need to rule out pregnancy, primary or secondary gonadotropin deficiency, non-classical adrenal hyperplasia, like the case mentioned in the previous session. We'll do a thyroid testing, we can proceed for more measurements of androgens, gonadotrophins, 17-OHP. In case of doubt, we can go for stimulation tests and imaging of the ovaries and adrenal glands, or dexamethasone in case of severe obesity. So, having mentioned the criteria through the most recent international guidelines and reviewing that together. So do you think that SOHA fulfilled the criteria of PCOS? So SOHA has hyperandrogenism, clinical hyperandrogenism, but she's still under workup. And of course, she is not yet pubertal, as was clearly stated by her Tanner staging and examination. But she might be at risk of developing polycystic ovary syndrome. And acknowledging the risk, yet to avoid overdiagnosis and premature labeling, is important to allow the reassessment of these adolescent girls as it is advised at or before full reproductive maturity. Its preferred timing is 3 years post-menarche in relation to menstrual cycle irregularity and 8 years post-menarche in relation to the use of pelvic ultrasound to identify polycystic ovarian morphology. The value of that and the optimal timing of the assessment should be discussed with the adolescent and their family, considering all diagnostic challenges at this life stage, as well as psychological and cultural factors. We need also to consider the emotional well-being when it comes to the management of these adolescents, as in PCOS, there is a high prevalence of moderate to severe anxiety and depressive symptoms in adult and likewise in adolescent girls. A meta-analysis observing that adolescent girls with PCOS scored higher in depressive and anxiety symptoms compared to control. Anxiety and depressive symptoms should be routinely screened in all adolescents with PCOS at diagnosis. If any abnormality in screening results, these adolescents should be referred to further assessment by more qualified personnel according to availability at your facility. Coming to the management, as you could see with SOHA, she's obese, she has hyperandrogenism, and for the management of the polycystic ovary syndrome, lifestyle modification as the first line, is preferably to be multi-component, including diet, less sedentary behavioral activity, less sedentary behavioral behavior, exercise, behavioral strategies should be recommended in all those with PCOS, and excess weight to achieve weight reduction and central adiposity with reduce also insulin resistance. Lifestyle intervention to prevent excess weight gain and not to wait for the obesity to develop. So we need to address and discuss the lifestyle intervention to avoid excess weight gain. 2 systematic reviews of lifestyle intervention in women with PCOS have shown improved in weight, hyperandrogenism, and insulin resistance. And a multidisciplinary model of care with dietitian, health psychologist, endocrinologist showed that behavioral intervention enhanced weight loss when combined with dietary intervention compared to receiving neither or dietary advice alone. The approach to management of the adolescent with PCOS should be a holistic approach, and pharmacotherapy should be considered alongside with education, counseling, lifestyle modification, and other options, including cosmetic therapy. We need always to inform adolescents and their family to the benefits and adverse effects of the and contraindication of PCOS and general population, of the medication used in PCOS and in general population. And we need to inform them of the fact that combined oral contraceptive pills, metformin, and other pharmacological treatment are generally off-label use for the treatment of PCOS. And we're recommending a pharmacotherapy to these children. Consider individual personal characteristic preferences, and you need to value this as important. The recommendation for the use of combined oral contraceptive pills, as per the international evidence-based guideline, combined oral contraceptive pills alone should be considered in adolescents with a clear diagnosis of PCOS, or could be considered on those at risk group for treatment of clinical hyperandrogenism and irregular menstrual cycles. And you preferably use lower risk OCPs to be recommended as the first line therapy. A meta-analysis evaluated the effect of metformin versus oral contraceptive pills, included 4 RCTs and 170 adolescent, have shown improvement in menstrual irregularities and in acne. Metformin, in addition to lifestyle intervention, could be considered adolescent with a clear PCOS diagnosis or with symptoms of PCOS before the diagnosis is made. So metformin and lifestyle could be started before, if you're doubting, and before the diagnosis, the final diagnosis is made. OCP in combination with metformin could be considered in children, an adolescent with PCOS and BMI more than 25 kilogram per meter square, where the OCPs and lifestyle changes do not achieve the desired goals. The combination, though with OCP and metformin, offers benefit, yet it did not exceed the impact of OCPs plus lifestyle intervention. So OCPs with lifestyle intervention first before combining therapies. Management of hirsutism. Hirsutism in these adolescents is very does affect their psychology, and they do value the importance of managing and treating this excess hair that they have on their face and other parts of their body. So we need to acknowledge the significance of hirsutism irrespective of the severity, and consider that as an important for the adolescent. We need also to discuss with them their expectation for the treatment and the results of the treatment. We need to address that the management of hirsutism is a long-term commitment, and more severe hirsutism will require a combination of strategies. Recommendations suggest that the use of OCPs combined oral contraceptive pills alone or with somatic therapy for at least 6 months before considering any androgen use, and this is by the international evidence and also endorsed by the Endocrine Society guidelines. Anti-androgens could be considered to treat hirsutism or androgen-related alopecia when the OCPs are contraindicated or poorly tolerated. And the use of effective contraception is essential to be addressed and informed to avoid any teratogenic side effects. We need always to screen for other comorbidities. There are comorbidities related to overweight, and there are other comorbidities that can occur with the PCOS, like impaired glucose tolerance, decreased quality of life, anxiety, depression, eating disorders, and altered body images. Adequate screening of comorbidities should be guided by symptoms, clinical examination, specific personal and family risk factors, and this could be followed by appropriate management to avoid further complications. As these kids will grow and will be transferred to adult care, we need to have the transition to adult care smoothly, and it is required for the adolescent with clear diagnosis of PCOS and those at risk to ensure their re-evaluation at an appropriate time and to review the PCOS diagnosis and management. So we need to take these adolescent girls safely to adult care. I will close up with the case scenario that we have started with. So with Suha, since we haven't reached got all the results of the investigation, we need to work up Suha for comorbidities that are related to obesity, including all metabolic abnormalities. And we need to plan for OGTT when needed, ultrasound to rule out NASH. We need to exclude other etiologies. We still have her 17-OHP results pending, and to plan for dexamethasone suppression test if needed, or ACTH stimulation test if needed. Time being for Suha, the plan of management to address all comorbidities and metabolic abnormalities as the results come. And we have started lifestyle intervention with metformin. The management, I usually consult our adult endocrinologists because they are more expert in the management of PCOS. So we do usually share the care for these adolescents together, and also with the OB-GYN, together with a dietitian and psychologist. And with that, I conclude. Thank you very much.
Thank you, Hissa, very much for your excellent presentation. And we'll open the floor for questions. I have one question from the audience to you, Hissa. Dr. Hassa, we see more and more of adolescent females with morbid obesity and clinical or chemical hyperandrogenism. However, with regular periods, no known classic, and they ruled out the possibility of non-classical CH. Does this fit PCO's definition?
So we have only one criteria, isn't it? We have hyperandrogenism.
Yes.
We don't have irregular menstrual cycles, and I'm not sure so we have clinical hyperandrogenism, so it's only one criteria. We do face a lot of children with that. I remember I had one child with adolescent with severe hyperandrogenism, with severe hirsutism, and I consulted my adult colleague. So to me, I will label her at risk, and I will continue to follow up this girl. I'm not sure about the age, but we need to continue labeling these patients at risk and reevaluate as the time passes. And I'm not sure if the panelists have any other opinion.
Yeah, I think it's very challenging when, especially for us pediatricians, we don't see much of these cases because most of us are following kids up to age of 14, and maybe they are presenting more to our colleagues in adult. But sometimes we do face these patients who are coming to us with this with clinical features of hyperandrogenism, with or without the irregularity in period. So it's really very sometimes challenging. And I find if the patient is having regular periods, no much of severe acne, we will just observe the patient and maybe work on the lifestyle modification and diet and trying to lose weight, especially those who have obesity on top of that. But I'm not sure what's the practice of others. Yeah,
totally agree. And the issue is that it's not only the lack of evidence, but also the normative value that we get from the labs. Sometimes it's not standardized to the population that we have. It's the reference ranges according to the age group. So we do face and the sensitivity of the test that we use in the lab. So the clinical and sometimes the biochemical you cannot even validate and prove.
Yeah,
I always call my adult endocrinologist to share the care for these children with me because they do have more experience.
Yeah, we do the same. Yeah, so I don't see any other questions, and I think that time is up. So I'd like to thank both of you. You had an amazing presentations, and were really enlightening and very thorough. الله يعطيكم العافية. شكرا.
Thank you, Dr. Afa. Thank you, Dr. Asma, for the nice and excellent presentation. Thank you, the audience.